Good morning. My name is Haley Muto, and on behalf of Better Health Together, I would like to thank Dr. Matthew Layton, Clinical Education Director of Mind, Brain, and Behavior at the Elson S. Floyd School of Medicine, for joining us. Good morning, and thank you for being here.
Good morning, Haley. Thank you for having me.
Absolutely. What we'll be discussing this morning is the current opioid epidemic. And to kick things off, Dr. Layton, could you please explain what addiction is and who it affects?
The simplest way to look at addiction is as a hijacking of the brain. And when we talk about someone being exposed to a different sort of chemical, we never know how they might react to it. So for example, if someone has a genetic predisposition to addiction, for example, addiction runs in families, just like other disorders like depression and anxiety and major mental disorders, addiction and alcoholism runs in families. The difference when we're talking about that opioid crisis is the way individuals have been exposed to substances that then act on their naturally occurring opioids in the brain and disrupt that process and, like I said, hijack the brain.
So is that why opiates are so addictive?
They're so addictive because of the withdrawal, arguably. The problem with opioids is that initially they can create a euphoric kind of feeling. And if you have someone who has had horrible childhood experiences or has depression or anxiety, and they take an opioid, sometimes they feel this sense of feeling so good like they've never felt before. And that does not last with opioids. The issue is that while taking more and more to try to get that same sensation or same feeling, you end up developing tolerance, which means it takes more and more of the drug to get the same effect. And then, because of opioids' addictive potential, you end up having withdrawal. And the withdrawal is described by various people as like the flu on steroids or the flu times 100. It's characterized by stomach cramps and nausea, vomiting, diarrhea, chills, cramps, muscle cramps, anxiety, sleep problems, runny nose. It's just a horrible feeling, and when one is addicted to opioids, unfortunately, they will lie, cheat, or steal to get well and get whatever it takes to treat the withdrawal. That's what seems to be driving the high relapse rate, is this horrible withdrawal. Even though it's not fatal, it's really debilitating, and they try to avoid it at all costs.
I see. Could you give a brief overview of the connection between long-term substance use and mental health?
We know the brain changes over time. That's what's most important to me, to think about the effects of these substances on our naturally occurring chemistry in the brain. It's this finely tuned instrument that has neurotransmitters, for example, that people have heard of. These chemicals that are in the brain, that things like serotonin and norepinephrine and dopamine, that have natural occurring roles to play. So for example, with opioids, we have naturally occurring opioids called enkephalins or endorphins. One way that people can relate to that is through runner's high, which is somebody who runs and gets that really positive feeling. That's a naturally occurring opioid. The problem is when you start taking what's called exogenous or outside opioids and putting them into the body, what happens is those natural mechanisms really get disrupted. So then over time, as more use happens, the years go by, it becomes harder to recover those normal or pre-addiction neuronal pathways. What's positive is that the brain is resilient, and that if we do stop exposing it to substances or get treatment, then we can actually recover.
Thank you. Now, what exactly is polydrug use, and what are the potential dangers associated with it?
Polydrug use is typically that multiple drugs are used simultaneously. So the idea is if someone comes into the emergency department with an overdose, what we often find in their system is that they might have marijuana, they might have alcohol, they might have benzodiazepines, anxiety medications, as well as an opioid. And the problem is that if you add alcohol with a pain medication, with a sedative, now you have the risk of accidental overdose that's separate in polydrug use from a straight overdose of opioid, where, for example, you inject too much heroin and that's the only thing you're using, in polydrug abuse, you have multiple chemicals that are interacting and often to harm the body's natural systems.
Okay. And we've been hearing a lot about the presence of fentanyl. Will you explain the implications of both the drug itself as well as the effects when it's combined with either heroin and or other substances?
Mm-hmm. It's a very potent form of an opioid. So, for example, it's used commonly in surgical procedures because of its very high potency. And so if you look at how morphine acts on the naturally occurring opioid receptors as your morphine equivalent, now if you look at other stronger opioids in potency, some measurements have fentanyl as much as 50 times more potent than morphine, which means an extremely small amount of it can cause an overdose. What's unfortunate is that it's being laced into heroin and people are getting exposed to it without knowing. And often they just think that it's a very strong form of heroin, but the fact is when it has some fentanyl in it, the respiratory depression that happens from the combination and the potency is what leads to the increase in overdose rates. So we're seeing people who think they may be getting strong heroin, but in fact they're getting fentanyl and they're accidentally overdosing and dying.
Okay. So this is a three-part question. Opioid-related overdoses seems to be a prevalent topic on media platforms widespread. So 1, who's at risk for potential overdose? 2, what are some of the signs and symptoms of someone who has overdosed? And then 3, what can be done for somebody who has unintentionally overdosed?
Mm-hmm. I think the way we approach that is anyone who's prescribed an opioid who may have a child in the house, that child is at risk for overdose. So even if we're not thinking in terms of the prescribed opioid for an adult, it's does the child have access to that medicine cabinet? This is also the same for adolescents. And what we're finding is that they're tending to bypass the liquor cabinet for the medicine cabinet. And they're drinking less, but they are consuming more substances that they get from their grandparents' medicine cabinets, for example. So a local campaign to try to educate the public really focused on elderly people with leftover medications in their medicine cabinet, parents of young children, and then parents of adolescents who are at that age where they might be at the skate park and a 16-year-old has broken their arm and got a prescription for hydrocodones or something like that. That individual may share those, and that's what starts the problem. So one of the goals there is to reduce the total supply of opioids by prescribing fewer pills for those problems like a broken bone. But the other thing is the risk of overdose is such that now the argument is we may need to provide the reversal agent, which we're going to talk about in a minute, Narcan, for anyone who gets an opioid prescription because the risk of overdose could potentially affect anyone in the house. The main signs and symptoms are slowed breathing and pinpoint pupils, and they start to turn blue. So literally they will have often a nodding where they start to look like they're falling asleep, but if you're falling asleep like that, you rouse up easily. When they're on opioids, they nod and they're harder to arouse. And so if someone is not waking right up when you're shaking them and they're breathing slower, they are on their way potentially to an overdose, and that is an emergency. And then the third part of your question?
Was what can be done for somebody who has unintentionally overdosed?
Right, so I mentioned Narcan or Naltrexone, which is the reversing agent. The way that works is it goes into the system very quickly. Most of the time now it's up the nose. It can be intramuscular as well. But the idea is it binds to the opioid receptors in the brain so strongly that it kicks off heroin or opioids like oxycodone or methadone, and therefore the person is able to wake back up and breathe again because it's blocking those drugs from causing respiratory depression. The problem is that by giving Narcan or Naltrexone to someone who has opioid use disorder, it causes withdrawal. It saves their life, but it starts them on a withdrawal path. So what's happening in some places, including New Jersey, is that the health commissioner is allowing emergency medical technicians to carry not only the naloxone reversing agent, but also Suboxone or buprenorphine to offer them treatment. So save their life with the short-acting Narcan, reverse the overdose, and instead of them having to go out and do it again and be on the revolving door, we could potentially start treatment on the spot.
Okay. And so you've talked a little bit about who should carry Narcan. So folks that are, elderly folks, parents who are using opioids or prescribed opioids. Where can you get Narcan?
You can get it at a pharmacy in Washington State.
And do you have to have a prescription for it?
I bought one for our sleep lab. So I bought a kit and actually got to try the process out, and went to a local pharmacy, and all I needed was my insurance card. It does not need a prescription. And the 2-pack that I received was 2 intranasal kits. And one thing that I would add is it's a short-acting reversal agent, so you may need to give it twice. And if the person starts to nod out again or starts to go back under before you can get them to the emergency department or something like that. But it is variable as to how much it costs depending on your insurance. And so what I'd like to see is for people who want to carry it and feel like they have the opportunities and will have to use it, that it would be more affordable.
I see. Thank you. So currently, what is Spokane doing to help individuals struggling with opioid use disorder?
Well, the Spokane Regional Opioid Task Force, I think, is a very good example of a community coming together from all walks of life, including education and city, county, law enforcement, first responders, care providers, academia. And we came together to really tackle this problem locally as part of looking towards the accountable community of health. The big picture is how can we look at the Spokane region and the opioid problem and partner together to have an impact on that. We met over the course of a year to plan out a day-long workshop, in fact, that had about 75 people attend and work on anchor strategies as to how to address the opioid crisis in Spokane. We came up with 5 anchor strategies, and they were essentially public education, the community education, provider education, so making sure that those who are prescribing or in the business are more aware of the risks and benefits. Non-pharmacological treatments for pain. This is another area that we have focused on. The more the public is aware of the risks of opioids, the less they want to take them for pain, and the more they would rather try something like acupuncture or massage therapy, or certainly non-addictive medications if they have to go to those. The other 2 had to do with the continuum of care, because people with opioid use disorder cross all sectors of society. They're often homeless, they are in and out of emergency departments and jail. And the continuum of care is, how do we put the person at the center of their care so that we have this continuity as they're crossing all these systems? And that's a big problem. And then the last one is first response. How do we address these situations, just like we talked about, where imagine being an emergency medical technician who has saved a person's life multiple times because of repeated overdoses, and starting to feel frustrated because we're not getting that person into longer-term treatment. So that's what we're working on. And then we were able to, out of that process, have a community event, bring in Tony Hoffman, who told an amazing story. He has an amazing history about his own addiction. And then we had a day-long community education, provider education event, which actually provided continuing medical education credits for doctors and nurses and pharmacists. That was very successful.
Perfect. So what are the options in Spokane for medication-assisted treatment?
There are mainly 3 types of medication-assisted treatment in the big picture. There's methadone, which has been around since about 1965, and has a very solid body of evidence as to preventing relapse. So people who have opioid use disorder engage in an opioid treatment program. They have individual and group counseling, they have peer support, they have medication, and that is the gold standard still. What we see is that when methadone is used appropriately, which is once a day for opioid use disorder, that it essentially prevents cravings when you stabilize. And there's no evidence of sedation or cognitive impairment over time as people stabilize on methadone. The Drug Addiction Treatment Act of 2000 allowed the use of buprenorphine at an office-based approach, so that somebody with opioid use disorder would not have to go to a whole methadone program in order to achieve abstinence, or at least what we refer to as harm reduction, where they are now taking an opioid, but it completely changes their life. They're able to get further their education. They often can get housing, they get a job, and they reconnect with their families. That's called a partial agonist, so it's not a full opioid, and that's why it's safer and it's regulated differently by the DEA. The third type is called Naltrexone, which is a complete opioid blocker. And the idea is it's an injection that you get once a month. And the problem with Naltrexone is it often has to come as the last step in a process of detoxification, medical stabilization, getting through the withdrawals in order to get to the point where now you can be without opioids in your system at all, and then you get a month-long injection. The good thing is that data shows that half of the people who get an injection like that come back a month later for another injection. And another area that I'd like to see us focus on that is that somebody is incarcerated in jail or in prison and has a high risk of relapse on opioids. Giving them an injection of naltrexone before they leave could actually save their life if they relapse and inject because they won't feel it with the blocker in their system.
I gotcha. So sometimes you'll hear people negatively comment about MATs and how it's substituting one substance for another. Can you speak to the accuracy behind this opinion?
It goes back to what we were talking about earlier, that opioids are not the same as alcohol or cocaine or marijuana or methamphetamine. They are different in their relapse rate. And if you look worldwide at studies that have been done to look at the relapse rate, especially around IV heroin, it's as much as 90%. There was a study that was done in Ireland a few years ago, and it looked at 160 individuals who came in for residential treatment for opioid use disorder, mainly IV heroin. They asked, the researchers asked if they could follow these individuals up for out to 3 years after they left the program to see how they were doing. What ended up happening was 3 years later, they could only find 109, so they couldn't even find 51 of them, and Ireland is an island. So you can imagine what happened, but of the 109 that they found, 91% had relapsed back to IV heroin, most within the first week. That's just one of 3 international studies that indicates the rate of relapse is 80 to 90+% within a year, and that is why harm reduction and focusing on the 90% who are not able to achieve abstinence only without medication. I'm happy for the 10% who can achieve abstinence without needing to take an opioid or medication-assisted treatment. But as a physician, I went to medical school to become qualified to prescribe medications for people who are suffering. And I see that 90% of people with opioid use disorder at high risk for relapse as suffering, and I have seen the medication-assisted treatment make a huge difference in their lives.
So where could someone go if they were concerned about a family member or friend who may be abusing opiates?
You can always call the anonymous crisis line. I mean, this is one way if you just don't really know what else to do. You could all call for more information at Eastern Washington 211 is another example. We have the Spokane Regional Health District Opioid Treatment Program, which is a place to get information. Certainly, we have syringe exchange programs for people who are actively using and who benefit from getting resources and information at that stage. If they're not quite ready to get into treatment, many of them are already thinking about it. And if the opportunity was there, that they would accept treatment. And I think that's the challenge, is often people end up in and out of treatment multiple times before they stabilize. And for us, the most important thing is to maintain our compassion and our empathy for that person with addiction as a disease that's hijacked their brain, and do everything we can to try to support them and assist them. And that's where medication-assisted treatment comes in. It is treatment, it's not replacing one addiction with another.
So I think it's really important to acknowledge the amount of stigma associated with opioid use disorder as well as other addictions in general. From a clinical perspective, do you mind sharing your opinion on the negative implications stigma has on folks struggling as well as our community as a whole?
It's guilt and shame, and it really is difficult enough to admit that you've lost control, that your life is in shambles. You've burned bridges with family members and friends, and certainly providers, who you may have taken advantage of. From my experience working with a lot of people with co-occurring addiction and mental disorders, the depression gets worse, the anxiety gets worse, and the thought of actually opening up and admitting this to their family or to their friends is overwhelming. And so the stigma is still there of this being some kind of a character flaw or a moral shortcoming. And I think that's why looking at genetics and the functional neurocircuitry and the evidence behind this indicates that not everyone has the same risk of becoming addicted. There are people who have a very, very high propensity of becoming addicted when they're exposed, maybe even just one time to an opioid. So to take that person and to place the stigma of them as being a bad person or immoral will lead them to stay in that cycle of lying, cheating, and stealing, rather than being able to admit that they have a problem sooner so that we can get upstream of those most devastating effects.
So are there resources available to parents and or caregivers to help them better understand addiction and how they can be supportive of their loved one?
There are, and I think that's the important thing about online resources is to make sure that they're valid and reliable. I would look at sources like the National Institute on Drug Abuse, NIDA, for the most evidence-based information about addiction. The Substance Abuse and Mental Health Services Administration as a government entity focused on providing information and data and reports around this. And the Centers for Disease Control and Prevention, CDCP, has guidelines for this as well. Those are very high level, and I think what often people need is a local, warm handoff, someone that they can connect to, and then hopefully bring in that education, that information that they've gleaned from online sources, and really commit to the process of going through an evaluation, talking with a professional, especially if you know it's interfering with your ability to work or go to school, your relationships, or your ability to parent. That's when we want to support that person, be there for them to answer their questions non-judgmentally, and then hopefully get them better.
Well, I really appreciate you being here today, Dr. Layton, and on behalf of Better Health Together and the Spokane Regional Opioid Task Force, we will definitely be posting when we have our next community forum coming up. Thank you.